Okay, Mani Nabudni everyone, and welcome to Grand Round for this week. I acknowledge that we meet today on the lands of the Kaurna people, and I pay my respects to their elders, past, present and emerging. I extend that respect to any Aboriginal or Torres Strait Islander people present here today, and welcome to those on Zoom. It's my great pleasure this afternoon, to hand over to Dr. Alice O'Connell, one of the Directors of Physician Education here at Carlin, to organise the whole Guha Prize presentation. Thank you, Alice.
Thank you everyone for coming today, and also thank you to Dr. Melanie Turner, who I think is online, for letting me take up some time before the presentation to present this year's Guha Prize. I'd also like to extend a special welcome to Professor Mitra Guha. He's here with us today to present the prize, as well as our nominees. So we've got some people in the room, and we also have some of our trainees who are nominated online as well. It really is a very special honour that I get to help facilitate this prize each year that celebrates our trainees. And I'm just going to, I guess, remind everybody of the criteria on which this prize is judged. So it's all of the trainees who've passed their clinical exam this year are eligible, and they're nominated by themselves, their peers, other trainees and consultant physicians across Callan. And these nominations are really a way to acknowledge both the academic excellence and that sort of achievement in passing their exam, but also, and I think probably even more importantly, to acknowledge the really significant contributions that a lot of our trainees make to the physician community across Callan. It's a community that we're obviously all a part of, and sharing that really wonderful culture of excellence, as well as a real dedication to training that we share, and as a really strong and enduring legacy that we've all had from Professor Guha, who set that up over many, many years. So we've got, this year we have 14 nominees, so you can see them up there and some of them in the room here. And they've all really contributed really actively to many aspects of the training program, though all of those contributions make it a really delightfully difficult job to try and choose just one winner each year. And just some of those sort of ideas, some of the things I just wanted to share of why these people have been nominated this year. So it's really broad, and lots of kind of different anecdotes that we get to hear. Some have been nominated for going really above and beyond in their clinical duties, particularly with regards to patient advocacy, beyond what we would expect of really quite junior doctors. Others have been acknowledged for their peer support, their mentorship, and their contribution to improving the training program and training setting for those that come after them. Some examples of this are some people that have been nominated this year have written quite heavily orientation materials for the trainees that come after them. Some have helped support their colleagues to prepare for senior roles such as night met lead, which is obviously pretty daunting. And others have offered to help many, many times to cover shifts to support their colleagues so that, that others are not put in a position of difficulty. Others have helped coordinate really quite a strong program of formal education with the training, the tutorial program, the written trial exams, as well as helping Bulldog and do lots of other on the ward teaching of each other and of our more junior staff as well. They're really all very inspiring individuals that I think we're really lucky to have part of our program, and definitely make our hospital a nicer place to work and train. And I think it will hopefully continue on and hopefully inspires others to continue in their footsteps. So without any more chat from me, I'd like to invite Mitra up to the stage to say a few words and present this year's prize.
Thank you very much, Alice. I had the honour and privilege just this weekend gone of attending the convocation ceremony for the RACP for people who have just come into the fellowship. And I said at the time that having spent a quarter of a century as a director of education, I thought that sounds terrible. Quarter of a century sounds worse than 25 years, doesn't it? But one of the things that has been phenomenal, I think, in the Royal Adelaide Hospital, and interestingly, it is recognised nationally, is the strength of our training program. And I think that comes enormously from the collaboration that the trainees in this hospital have always done, that they work together as a group and they support each other and they pull each other up so that everybody is moving ahead. And I think the nominees here are examples of how this process takes place and which makes this place a really remarkable training organization. So I'd like to congratulate all the people who have been nominated. I think you've all done a wonderful job, and I hope this tradition will, I'm sure, given your own handing down that tradition, will continue with the juniors under you. It's my very great pleasure, therefore, to announce the winner, and it's always hard to pick a winner, but there is one winner of the prize for this year, and that is Caitlin Shahadi. Yes. Come on, Alice. Come on, Alice. Congratulations, well done.
All right, well, thank you very much, Demetra. And thank you everyone for coming along. It's great to have so many of our nominees here this year. And I will try and find a presentation for the next person. No presentation.
So I'll now invite our speaker who joins us today, Dr. Melanie Turner. Melanie is a psychiatrist with the Office of the Chief Psychiatrist, and hopefully she'll be able to share her screen so that we can see it.
Yep, I promise I am. Alrighty, so can everybody see my screen? And I can, yeah, I'm going to hear mumblings and everyone can hear me okay? Fantastic, thank you everyone. Bear with me while I do that. All right. Okay, so thanks everybody. Sorry I'm ringing in from my office today, which you can see behind me, but Christmas time of year when you do child and adolescent psychiatry always lends itself to lots of referrals, so it's been really hectic. Thanks for asking me to talk about autism in adults. This is me, so I'm a child and adolescent psychiatrist, done my PhD and some other bits and pieces. I'm Deputy Chief Psychiatrist here in the Office of the Chief Psychiatrist. I'm a board director on RANSCIP, and I'm also the presiding member of Voluntary Assisted Dying Review Board here in SA. So if anyone's keen to find out about that, feel free to get in touch with me. It starts to be available January 31. But this talk is really about autism in adults. And I suppose the goal really is to try to help understand autism a bit more as there's more and more people diagnosed with ASD. And we're asked, I suppose, to understand them as patients and people and look at how they kind of navigate our health system. So the tricky part, I suppose, around autism spectrum disorder, particularly in adults, is that most of the data we've been looking at for quite some time has really been very focused on children. So the data that if we look at from 2015, we thought about 1 in 150 Australians, or 0.7% of our population, we thought to be on autism spectrum disorder in some way. Over the past 70 years, we used to think it was really rare, so 4 in 10,000 people, down to 1 in 100 people. If we look at really what is probably the more modern ratio, it's probably something like 1 in 60 to 70 at the moment. I'm always asked, you know, why is there this increase? What's happened? I think in actual fact, one of the things we've seen is that there is a lot more, there's a wider definition of autism spectrum disorder. Historically, when, you know, I was not a doctor, but working in other, you know, areas, we thought autism was really defined by people's intellectual impairment and severe speech impairment. It was viewed as something that mostly presented in people who required special school education and care. And as time's gone on, and when we looked at Asperger's as a disorder, we then widened to autism spectrum disorder, and DSM-5 then really opened the door to having us all consider what spectrum really means. So we then had more people seeking assessment. The NDIS, for better or worse, rolled out for children quite early on in its program, so from late 2009. And the NDIS initially was meant to provide funding and support for people who had difficulties related to a disability, but we initially didn't need to provide diagnoses. There was really an understanding that everyone had different needs, and that's what the NDIS would cater for. However, that reasonably quickly moved towards people having to have a diagnosis. And in particular with autism, we're always asked to give people a level because there's 3 levels, thanks DSM-5, of severity of autism spectrum disorder. So that really drove a lot of people to seek a diagnosis. So all of that increased, our prevalence rates, and the true increase in prevalence is probably due to some unknown reasons that we don't really understand yet, and that the history books will probably tell us. Why do adults seek an ASD diagnosis? Well, adults, often when they come and see me with their children, are often wondering whether their child is like them because they had autism, or whether their child is like them because it's just, what it is to be a family member and shared genetics. But often they describe a history of difficulty understanding and abiding by social rules and relationships. So getting into trouble at school, not really sure why you are, feeling really clunky and awkward around others, difficulty maintaining friendships, feeling that you're lost amongst, the complexities of teenage friendships at school. One of the others is significant problems with executive functioning and organisation. And this often comes up with people talking about difficulties with understanding the workplace. Applying for jobs can be a challenge. Understanding kind of the rules around working in a team can also be a problem. Notable sensory sensitivities to sounds, textures and food. So people who have not been able to get on the train or get on a bus because of the sounds, people who are embarrassed because they don't go out to dinner because they might only eat 5 or 6 foods, or people that still wear a very narrow range of clothing to manage their texture needs. Difficulty maintaining a job because neurotypical social skills might be really important. So you might need to network, connect, supervise, delegate, allocate, and all of that can be very difficult if you don't have a strong sense of social connection. You can come across as rude, blunt, dismissive, and they can be perceived as not fitting in a workplace. They might also feel a sense of not belonging and not having meaningful friendships or relationships with others. They can often be quite lonely. And they often want to really understand their struggles when they were kids and adolescents, particularly if they're parents as well. But what happens then if you are trying to find out what's going on for you? So, Dr. Google is where most people go, but what happens if you actually go ASD or autism assessment in Google? So the lovely screen on my right, do you have symptoms of autism? The following online adult autism test helps identify whether you have any traits of autism. Why is it worth taking an online test? Take this quick online autism test now. And people who are unsure and embarrassed, this is where they first go. And you never know what they're going to tell you. And then you get screens like the next one. This one, an online interactive autism test for adults 16 years and over. And this one actually says that the test is fun too. So or do your autism test and have fun and find out, which is obviously misleading and confusing for people. So if people really wonder whether they have autism, they need to look a lot further than just some of the search engines. And then they wonder, where to next. So identification and assessment of autism in an adult, what do we look for? We're classically taught what to look for in kids. And children have a reasonably well-developed map of psychological and physical development and social development. We have clear school expectations, learning expectations. We can assess all kinds of things. Once you're an adult, though, we don't have any more of those developmental scales, really. And so we need to look for different things. I would say that, in general, we'd consider assessment for possible autism when a person has one or more of the following. So they need to be persistent difficulties, because autism is pervasive. And if you have it as an adult, you had it as a kid. So it's not going to be something that's brand new. Persistent difficulties in social interaction. So this is often meeting new people, starting a social conversation, being able to feel comfortable in a group of people, even if you know them reasonably well, working out how to move in and out of social circles and conversations. Difficulties in social communication. So this might be greeting people. It might be, having that first, everybody say sitting together at some sort of event and working out, how to strike up a conversation, when to interject, when to pause. Stereotypic behaviours. So rigid and repetitive behaviours. This often we describe as kind of concrete kind of behaviours, or people seeking patterns, and people also trying to avoid anxiety. So they might only catch, the 7:25 bus to work. And if a 7:25 bus doesn't come, they might not get the 8 o'clock bus because they don't feel right if it's not the 7:25. They might have repetitive behaviours they need to do when they get to work or when they're at home. They might be things like needing to stack everything in the cupboard in a particular way each time they come in to do the dishes, and they can't be interrupted and they can't have anyone else do it, or that doesn't feel right for them. They'll get quite anxious. Managing change can be very difficult as well. Change represents anxiety for a lot of us, but often we're able to rationalise and give ourselves other examples of why change is okay. And our brain does that quite quickly. If we have autism, our ability to manage change, it can be limited, because our ability to compare and use other examples to reassure ourselves can drop off. They might have restricted interests. So they may be very intensely focused on a particular basketball team. That might be the focus of all of their conversation, their hobby. It might be everything they watch, everything they think about. It might be all they do on their weekend, to the point where it's such a large interest that they don't really move beyond that, and it's very hard for them to work outside of that in a social setting or talk about anything else. They also really need to have one or more of the following. So problems in obtaining or sustaining employment or education, difficulties in initiating or sustaining social relationships, previous or current contact with mental health or learning disability services, history of a neurodevelopmental condition. So mostly we're looking at some of the pervasive developmental disorders like autism, but also some of the genetic inherited disorders as well. So Fragile X would be one of those, including learning disabilities and ADHD, or a mental illness from an early age in particular. If you're seeing someone and you think they need an ASD assessment as an adult, what do we do? If they come into my room, how do we do that? There are some gold standard assessments. So years ago, people would just sort of do an interview and tick some boxes and say, yes, this is ASD. The standards changed now, and there's an expectation that you would use something like this, which is called the ADOS-2. It's a semi-structured observational assessment, and it covers 4 different domains. The coloured books there are the books that you hold on to that actually have all the components you're assessing, and you write and fill those out while you do the assessment. This probably takes, if you do it properly, at least sort of 2.5 appointments. So, a couple of hours overall. And it covers communication, reciprocal social interaction, communication and social interaction together, imagination, creativity, and stereotyped behaviours and restricted interests. So you actually do activities with the adult during this time. So you will actually look at there are some pictures, and you talk about what they see, what catches their eye, what they're interested in. There's a book that they look through and they give the narrative to you. There's a creative story section that they do. And then there's one where they'll need to demonstrate a particular life task to you, so washing hands or brushing teeth. And there's a standardized way that you look at all of those different tasks. And then there's a interview section, which will talk about how the person connects with family and friends, how they perceive friendship, how they perceive challenging relationships. And so you work through all of those steps. And you choose the model number based on the age and developmental stage of the person. So they go from toddlerhood all the way up to adult. You need specific training to do the ADOS too. The other one that we often use is not an observation scale, but it's a semi-structured interview. So this is the ADIR, and you can see the picture there on the screen of the different components. It covers 3 areas of impairment in autism. So the quality of the interaction that the participant has with you, communication, repetitive, restricted and stereotype patterns of behaviour, which is abbreviated to RRB, repetitive restricted behaviour. Now, a prominent part of this interview, and it can be troublesome for some, is that because we're always looking at the early years development, it does focus on the period between the ages of 4 and 5. So sometimes you'll need to have parents in the room if the person doesn't know their own narrative. So if you've got a young person who's 19 and 20, they probably do need someone who knew them when they were younger. That's because the differences among individuals with different levels of functioning can be better observed, often in that younger age group. And as I said, that's because we have those standardised developmental expectations, learning expectations and physical expectations for children as far as their development's concerned. So this is really just a summary slide. So this is being recorded if anyone wanted to go through. So these are the diagnostic tools that are most commonly used. There's the adult Asperger assessment, autism spectrum quotient and empathy quotient. Then there's the ADIR, the ADOS, the RITVO, which is on here, is actually quite a helpful one if you're trying to work out autism Asperger's in someone who has a trauma history as an adult. It is a bit more complicated, but can be quite helpful for some of those more complex patients. And then you can see that there's one's called the ADOS-G and the different version of the ADIR for people that have a learning disability. You always have to be aware of the speech and language component you expect people to have to complete your assessment, because if you're expecting them to be able to talk their way through describing a picture book, you've got to make sure that you're putting it at the level academically they're able to manage. So what gets in the way of people getting an autism diagnosis as an adult? So there was work done by Arnold et al. And Huang in 2020 that really said pretty much across the world that there's a high and prohibitive expense of getting an autism diagnosis. So for children and adults in private practice, you're probably looking at anywhere between sort of, $1,000 to $2,000 to $3,000 for people to go through a number of assessments, depending on what they are. In public, as an adult, it is very difficult to access an autism spectrum diagnosis, and that's often because the people with most experience are paediatrically trained, and so the public clinics tend to not have as many people with paediatric experience seeing adults. Once people get a diagnosis, the other thing is that there might be a lack of supports or services. So people may not feel that it's worth actually getting a diagnosis because they won't be able to get any extra assistance. It is a challenge with the NDIS because in general, they want you to have level 2 severity out of a maximum of level 3 of autism to receive NDIS funding. So if you have below that, you're likely to be declined. And And psychology therapy or speech therapy or a social group intervention is probably hundreds of dollars per appointment. So for some people, it feels defeatist. The time delay between suspicion of autism to your diagnosis, we're probably looking at people waiting somewhere between sort of 6 to 7 months to 18 months to be able to get a diagnosis. That's a really long time to wait if you're trying to make some important decisions about your healthcare or about your relationship. And the lack of support for just services for autistic adults in general can be a difficult one. There's not as nearly as many programs for people with ASD as adults, even around just psychoeducation, as there are for children. The other challenging part is about you've got to have, you know, some expertise in understanding kind of autism in a developmental perspective to be able to do the assessments and be a treating professional. Well, obviously, everywhere is short of every health practitioner at the moment. And we're certainly short on people who have really strong developmental kind of pathway training to understand ASD in adulthood. So the lack of services available post-diagnosis, a lot of people comment on that, I've got this, now what? They're not sure where to go and what to do. And if you have autism, it's overwhelming to reach out and ask for help as well. And when you do diagnose someone with ASD, you have to be really comfortable to have a lot of sensitivity around the diagnosis. You've got to have time, you've got to have a quiet space. And you need to be able to help the person navigate what to do post-autism. And so trying to find all that together is a very challenging thing at the moment. The other question I'm asked is, you know, are people with autism actually, you know, is their brain different in some way? And kids are lovely. Kids will ask you that straight out. Adults, it takes them a while. So the best way we really know whether brains are different is when we scan them. So the question is, do ASD brains appear different when scanned, or are they the same? Honestly, the jury is still out. We don't have huge studies, and that's because scanning people is difficult. The ethics of scanning children for this stuff is not great. And so we have small numbers with small amounts of funding, really. Some show changes and others don't. It looks like some people with ASD have brain changes that we can see, particularly on MRI or PET scan. So some have shown that there is abnormal age-related changes, particularly in frontotemporal and striatal regions that you can find in early childhood and adolescence. fMRI evidence that the sustained attention brain networks are activated abnormally. So they're the ones that allow you to focus, concentrate, retain information, aren't working as they should. And that the frontostriatal cerebellar networks also seem to not mature in the same way and as quickly as they do with people without autism spectrum disorder. If we're to look at the Lancet, and I hate the words, it's a busy slide, but I don't expect you to read this slide verbatim, but if we look at, this is really the progression of MRI measurements over time that we've been able to work on as we look at ASD in the brain. So the top left is, just looking at brain volume, and then we're able to move on to grey and white matter changes, then regional brain volume, then morphometry, and then we looked at sulci. And then as imaging became more and more advanced, we're able to look at different types of imaging around diffusion and cortical thickness and, you know, measurements in different parts of the brain that we just couldn't really do previously. So that's giving us more and more information as we go along. And I suppose that what we think is happening is that there are changes that probably are too subtle for us and our current science to really define really well for us, but we seem to have picked up on the fact that for a portion of people with ASD, there are structural brain differences, in particular with their ability to socially communicate, take on and retain information, and to cognitively integrate what's happening around them and make sense of a narrative. So if you're seeing someone with ASD, you know, what are the comorbid things to keep in mind? So they did a reasonably large study in Ireland. It finished in 2021, I think. And their stats are that a quarter of the general population have problems with mental health at some point in their life, which is probably similar to ours. But if we look in people with ASD, the number is much higher, with about 80% of people with autism experiencing mental health issues during their lives. And if we break that down and we look at the subtypes of disorders, anxiety disorders are diagnosed in about 20% of autistic adults, compared with only 8.5% of the population without autism. And some said even, you know, the rates of up to 50% prevalence of anxiety symptoms. Certainly as a clinician, the level of anxiety in people with autism is much higher. They do not all reach the threshold of having a diagnosable anxiety disorder, but the current thinking is that having to navigate a neurotypical world with ASD is just inherently anxiety provoking, because there are a lot of things happening that you're unable to make sense of, which makes you feel uncertain of what's going on, which gives you anxiety. If we look at depression, some research says that up to 70% of people with autism have had at least one episode of depression in their life. This includes adults. I think that's an overstatement, but I think that it is more likely in people with ASD for a similar reason, that they often can be disconnected from the community, and social connection can be very difficult. And so what that means is when they're going through a really challenging time or they're feeling quite depressed, their ability to connect with others and be able to receive support is less, which means probably they're developing more depression because of the early protective factors are less present for them. They're also, if you have autism, you're 3 more times likely to develop schizophrenia. There was a big brain study done in the US that showed that they felt there was a brain link between ASD genetically and schizophrenia, although that's, you know, not a clear pathway. It's really kind of a proposed idea. But, you know, that's a significant number of people presenting with ASD and psychosis. And it means we need to think about that not every person with ASD who's doing something odd or bizarre, it's just ASD. We need to consider schizophrenia. And the other thing, I look after a number of transgender people, is that being transgender or a gender diverse individual is much more likely in people that have ASD, somewhere between 3 to 6 times more likely. And there isn't clear research done around that at the moment, but for those of us that work with people with ASD, particularly in their teens, identity and where they fit is a big issue. And certainly gender and sexuality becomes a topic because that's got a lot to do with relationship and working out who they are as an individual, so gender, and who they're attracted to, so sexuality. And I think that for some people, they're unsure where they fit, and then they kind of are looking to see where they identify. So a number of people are gender diverse. My next slide talks about ASD and suicide. The reason I brought this one up is that I think it's important to know that these people have a much higher risk of attempted and completed suicide. They're much less likely to have personality disorders in general. So a lot of their suicide attempts come out of a point of distress or untreated or undiagnosed depression and anxiety. And it often isn't recognised that it's more frequent in people with ASD. And so taking time to ask the question and listen to their answers as far as suicidal thinking or suicide attempts is really crucial, because those discussions are going to be usually overwhelmingly anxiety provoking, and a person with ASD will need longer to process what you're asking in general and will need to have gentler questions. They also talk about in quite a large scale study, and I'm sorry for the very long reference down the bottom, but you know, they found that people with ASD were more likely to contemplate suicide than the general population, and even more likely to contemplate that than people with psychosis. So it's a very reasonable question to ask, and it's for often it's an indicator of loneliness and isolation for people with ASD, and hopefully if we ask the question allows us a window in to provide support. People with autism are also more likely to show up to a general hospital, more likely to go and need medical care. So more than half of autistic adults and carers in the Jariwala-Parikh study reported they'd had hospital contact in the last 2 years. Often that was an outpatient admission means an outpatient clinic, and you know, seeking medical assistance and support. They often had co-occurring conditions. Pain was quite high on the list, anxiety, people having an accident with an injury requiring emergency presentation and then outpatient follow-up, so fractures, burns, sutures, depression, gastrointestinal problems, often relating to chronic gastrointestinal problems, and infection. And suicide attempt was the most reported reason for the most recent contact. So 7% of autistic adults and carers. So if you're seeing someone who has ASD in hospital, what are the clinical approaches that seem to be more helpful? I suppose that if we look at the actual patient themselves, so on this wheel here, you can see that it looks at communication differences. So do they need something different? Do they need something to be written? Do you need to come back to see them? Do you need to wait until they have someone who's a member of their family to support them? The need for predictability. Many people with ASD like to know what's going on, who's coming, who you are, what time, and when to expect things, which can be a challenge in a busy hospital. Preferences for routine. So if they have a routine that's important to them, if they can have that in hospital, that's good. So if it's a routine about showering or reading a book or watching a particular program or ringing a particular person, ensuring those continue to happen can be very reassuring for them. And from a sensory point of view, hospitals for many ASD people are overwhelmingly loud, bright and smelly. And that can really affect their ability to want to be in hospital or have their treatment. If we look at what helps from a healthcare perspective, having things like people aware of autism and what a person with ASD may need and what the environment they need might look like, really clear, unambiguous communication, because people with ASD have difficulty interpreting our subtleties and vaguenesses. So something that's clearer is helpful. So you might say, the plan is tomorrow you would have a CT scan. The plan is it will be in the morning, rather than say you'll have a scan. That kind of open question can lead to a lot of anxiety or open statement. A tolerable environment. Obviously we can't change the hospital, but they might need noise cancelling headphones, or they might need to have their weighted blanket, or they might need to be able to have a break off the ward or something to be able to help them manage the space. We've looked at some of the barriers to healthcare. So a number of people with special needs have had a negative experience at a hospital. So even just wayfinding, working out where to go to the clinic, following all the signs, getting in the right lift, they can be really anxious before they get there. People with ASD can be labelled as difficult. They might sound difficult. They might have a really blunt way of speaking. They may talk over the top of you. They may seem dismissive. From a communication point of view, it's not just the words, but the way they communicate can be very difficult. And again, the sensory challenges, they might refuse to wear a dressing, put on a gown. But the reason we address all of this is over on the left-hand side of our circle is we need to look at what the adverse consequences are. So delayed presentations, increased morbidity, increased mortality, non-presentation, or you might find that if the person is continually overwhelmed, that they're going to become so distressed that you need to intervene in a psychological, psychiatric way until you can go back to mainstream medical care. I know I've only got a few minutes to go, but this was developed by the NHS for their staff, and it looks at if you have a person in ASD distress, what are the things you can do? So this broke it up into check. So it looked at communication. So check if the person can communicate what's wrong. Are there any needs you need to be aware of? So if something's looking pretty pear-shaped and the person's upset, do you ring their next of kin to kind of seek some help to kind of translate what's going on? Has your communication been okay? Did you promise something that didn't happen? Was the scan rescheduled for another day and they're now sitting there waiting and they don't know why it hasn't happened? Does there need to be an adaptation of how you communicate? Do you need to write it down and have it as something they can read after you've left the room? Health, checking person's physical and mental health needs. So a lot of people with ASD won't communicate pain in the same way. They might have a lot of pain, but not say much. And are there physical health issues that are affecting their presentation? Environment, is it too noisy? Is it too bright? Checking in with them if it is, seeing what you're able to do that. Are they sensitive to touch? Are they uncomfortable where they're sitting? Change, if there's been a big change in the day, a change in staffing, to check in, tell them who you are and what the change has been. And if someone who knows them well can kind of reassure them that this is what the change is, or ask someone who knows them well what might have caused the distress. And then knowledge, like, you know, what's normal for the person, what treatments are they already on, you know, is there a plan already in place? So it's kind of a bit of a, we do this for most of our people in hospital all the time, but it's just a reminder that there are some extra things for someone with autism. All right, so I'm almost at my last slide. Really, this was my, you know, Mel kind of run through version of, you know, adult ASD. I think the takeaway is really that autism spectrum disorder is more commonly being diagnosed in adults, and you'll have many of them sitting in your hospital today. It's an expensive and long process, and you might meet people who are still waiting for a diagnosis or waiting for an assessment or saving for an assessment. It would be great if we had more availability of adult assessment processes to also tell people who don't have autism that they don't, and those who do that they do. For many, it's helpful for them to have the diagnosis because it will clarify what they've been wondering for some time. And then for others that don't have ASD, it allows them to focus on what else might be actually causing the problem. And it may be that they just have a very significant anxiety disorder, and that then you can focus on treatment. That a range of social and emotional, cognitive and sensory difficulties are present for a lot of these people. And that colours when they present to hospital, it colours their life, where they work and who they spend time with. And I think we need to be aware that there's a high risk of mental and physical illness, so keep that in our mind whenever we're looking after people with autism. All right, I think that brings me to the end of my questions. So I'm just open for questions, brings me to the end of my talk. So Jo, if you're happy, I can stop sharing. Bear with me while I try to stop sharing. Okay, I think that brought us back and my screen's gone, is that right? Excellent, cool. All right, so are you happy for me to read from the chat, or would you like to?
Melanie, can you hear me now?
I can now.
Fantastic. Sorry about the delay.
No, all good.
Okay, thanks so much for that presentation. You've really clarified some of the things that would make it easier to care for someone more comfortably in hospital with autism spectrum disorder. I think I was very much, I guess, touched by the statement you made about difficulty with having appropriate services to access. And I think within the hospital system, many of us are probably more familiar with patients with severe autism since childhood coming in on lots of medications who are perhaps labelled as having and certainly do have challenging behaviours. They tend to be stranded in hospital for a very long time. And I just wondered if it was within scope of this talk for you to talk a little bit about medication management, which we often get pressured to prescribe as generalists.
Yeah, no, it's a really fair question. And if it's any consolation, I have a similar group of younger kids in a similar boat. I think medication management is a part of the puzzle, and a lot of us have to struggle with that because appropriate accommodation and safe accommodation often isn't available for these people to have and go home to. And really experienced people looking after them who are able to provide the kinds of interventions that seem to work. And I think if we look at what's recommended, the idea of having, 2 carers 24/7 in a house that's reasonably robust is kind of what we need. And the reason why looking after these people in hospital is that isn't possibly what you can have in a hospital bed. So what do I do with medication management? I try to split it into what behaviours am I trying to help the most with? And I go back to kind of, are they anxious? Are they depressed? Are they impulsive? Are they aggressive? Can I work out what the impulsivity and aggression may be too? Sometimes, as we know, people with brain injury or people with severe intellectual impairment, there are parts of being impulsive that are part of their permanent cognitive impairment, part of their, brain. So I try to, number of my kids are on polypharmacy. I do use antipsychotics and I do use mood stabilisers for a number of aggressive, dangerous behaviours because I think we need to manage risk. I always say the lowest, most effective dose is what we aim for all the time. And that I also try to make sure that gets reviewed so that I'm not just adding to the top, but I'm actually making sure what I'm using is helpful. Because what we find happens is sometimes, 2 doctors will start 3 medications for someone, and then someone else will start something and someone else will start something. And before you know it, someone's on 18 medications. So I think another part of our job is if they're on sodium valproate and they're on the maximum dose and they're still extremely aggressive, and the valproate's not treating a seizure disorder, and in fact it seems to not be doing anything, then we need to really decide whether there's any use for it at all, and then you need to replace it with something else. And when they leave the hospital, they need a doctor who's able to take over that and continue to reshape and refine their medication. And it is really difficult because these are all individual people. Their communication's limited, so trying to get side effect, pictures is very difficult, which is where really good staff come in because they need to tell you about side effects and effectiveness. So I don't know whether that's helpful, but, it's really complex and it's really about reassessing where the symptoms are coming from, trying a medication for the most appropriate dose for the person. If that's actually not effective, you really need to look at replacing that and getting rid of it. And you need someone to provide ongoing follow-up so that it gets reshaped and reassessed, at least every few months.
Thanks. Yes, I think some of us are familiar with that long course of action in people who can't actually describe much of what's going on, and also unpacking whether there's physical illness.
Oh, really hard, particularly pain, particularly abdominal stuff and dental stuff. It's really, really difficult. Absolutely.
And I think the biggest challenge is getting someone to partner with you as a clinician to look at those specifics, because many people are very afraid of these patients with, reason, of course. I tried in vain to show the chat on the screen, but I guess I'll just read from my screen, and I know you can see it too. So Wayne asked, if there is an uncertain discharge date, how would you communicate that?
I tend, if I'm talking to some of my patients and we're looking at treatment, I tend to give a range. So if I can say that the plan is that, between Monday and Friday, we're waiting for X, Y, Z to happen, that will then tell us when you're ready to go home. So if you can set some parameters, you know, so they've got an idea of why it's uncertain, you know, you're waiting for pain to go away, you're waiting for, you know, I don't know, whatever it is, whatever procedure or whatever medication to work. So they know the markers that you're using, and then kind of putting a top and tail to, you know, that assessment time. It's not too bad. It depends on the communication skills too, but that's what I tend to use. And often if they develop trust with you as the clinician, then they trust that if you're coming in to talk to them, that they can trust that you're working towards their discharge date. So there's also that old school relationship stuff.
There was another question on the chat from Tim saying, with the SA Minister for Autism and the associated strategy that is currently under consultation, do you think this will have a benefit to public and or private practice?
I hope so. I met with her a couple of weeks ago, and I think at least it's got the advantage of bringing some focus onto autism spectrum disorder, and a recognition that there are gaps in the services and that there are gaps in understanding. So yes, I think it will make a positive effect. I never know how quickly though. We would all like it yesterday, and I know that's not going to happen, so I'm just going to have to be patient.
Okay. Any questions from the floor? There's another question in the chat from Al saying, I am pondering how ASD affects people who are themselves dying or who are close to someone who is dying. I think we under-recognise this as a factor in palliative and bereavement care. What has been your experience in this domain?
Yeah, look, I find that talking about death and bereavement with people with ASD is, it's really overwhelming for them. The emotions that come up can feel quite unbearable, as they are for all of us. But if we think about autism being a challenge with knowing your own emotional state and an understanding of your own emotional reactivity to be grieving or to be in bereavement can be incredibly overwhelming and disarming. And so I think that we are used to people who are grieving just being sad, but some people with autism might be quite annoyed, they might be quite bland, they kind of process it in a very different way. And I think they also they take a longer time in general to process it. So there's often, I have a lot more discussions with my patients about death than I would with a neurotypical person. So we might still talk about bits and pieces of it a number of months afterwards, because some other thought will have come up in their mind that they hadn't thought of before and they don't know where that fits. And, you know, I think we haven't looked through from the VAD process point of view, but I think, you know, just the pathway about helping people, you know, have a partner to help them go through the process of someone dying. We probably need to consider that with people with ASD in any setting, oncology settings, palliative care settings, because they need someone to help them guide through some of those more overwhelming parts.
Thanks. I wanted to ask you one question about psychology support, which I think many psychologists are quite happy to see someone who's fairly good at verbal communication, but I've found nobody particularly interested in seeing someone with limited verbal communication skills with autism. And yet I really instinctively feel that that should be beneficial alongside of medication management. Mm-hmm. Can you recommend any particular services, or are there people that choose to train in this area?
There's a gap here. So in psychiatry over in the UK, they have a developmental disability subspecialty and a disability subspecialty. And they see that particular population, so intellectual impairment, significant communication impairment, neurodevelopmental disorders, all sit amongst that. And alongside that, there are psychologists that do similar kind of training. Here, we don't have that same stream. So we have developmental educators that will work with those people as children. And we tend to have people who work as behaviour intervention, positive behaviour intervention specialists that will work with children. But you're right, I haven't been able to find people that extend that up to adulthood. And more often, my patients under 20 who present like that, they get a lot of input from occupational therapy. So they'll actually do a lot of that work through mental health, OT with a mental health kind of framework. And that's been extremely helpful. NDIS changed that landscape though. Prior to that, we probably had a bigger disability SA kind of focus where we had, there was corporate knowledge there about this population. And now we just don't have that because a lot of it's been fragmented and popped into all these private companies. So that's, I think, why we find it so hard.
Okay, we've got a question from the floor for you as well, Melanie.
Mm-hmm.
Yeah.
Could you discuss what the lower limit of normal sociability and interpersonal skills is, and where that is differentiated from a disorder?
Yeah, that's a good point. So I suppose that we would say that from an ASD point of view, the person would still, they need some of those really core criteria. So as far as the social and emotional kind of difficulties, they have to be pretty extreme across the board in all environments right from childhood. So it's parts of it are like, really never having a true friendship, not ever being in a sort of positive, socially kind of connected group, or having to be on the fringe of the group all the time to be included, or having friendships that very frequently just break and don't continue to exist. And that actually occurs despite lots of support and lots of different environments and lots of different places. The social communication really looks at the ability to initiate a conversation, hold a conversation, and be able to take turns in sharing a topic and take turns in talking about things that each of you are interested in. So there's some of the core parts that we kind of assess. But it gets more complicated than that because you also, when you're doing a good history, you then go through developmentally just things about tolerating change and restricted interests. So those are the other two things that you also look for. So I don't know what that, so it's all of that together. If you just happen to be a very shy person and you don't like people very much, that doesn't give you autism. In the same way that, being an extrovert doesn't make you a narcissist. It's really about sort of how those other parts of your life fit together.
I think that your last statement was a fantastic soundbite, Melanie. And you can't see it, but there's lots of smirks and smiles in the room. So you've hit the mark there. And I think that's right. I think it's a little bit horrifying how autism gets thrown around as an insult sometimes, but I actually think what you've shown us is a proper diagnosis and an understanding can be very, very helpful. And I do wish that there would be some more services flowing from that particular sphere end of the spectrum. I think you're right. The Centre for Disability Health closure some time ago has been a major gap for my practice in outpatients, actually, because I see a lot of these young adults, but hopefully things will improve, and I'm going to look for a good OT. Sounds like a great plan.
Yeah.
I'd like to thank you very much for your presentation today. Do you want any final words?
No, thanks for having me. Apologies, I'm not there in person. I'll just assume that you're all in awe and so excited that I came to speak and all that kind of stuff.
Melanie, the technology works really well in this room. So we've seen your slides and yourself very clearly. You're about 8 foot tall on the screen.
Thank you.
Stop
Thank
sharing
you.
Slides. I'm so sorry. I'm standing up here with you though, so I'm sharing the pain. All right. Thank you so much, Dr. Turner.
No worries. Thanks, everybody.